Welcome to this Clinical Care Options and Practicing Clinicians Exchange podcast. I'm your host, Courtney Duval. Today's episode features a discussion on strategies to address social determinants of health in non-valvular atrial fibrillation. This episode is part of a larger educational program titled The Biggest Risks to Cardiovascular Health, Addressing Social Determinants of Health in Non-Valvular Atrial Fibrillation. During this podcast, Dr. Keith Ferdinand, Professor of Medicine at Tulane Heart and Vascular Institute and Tulane University School of Medicine in New Orleans, Louisiana, and Dr. David Kountz, Professor of Medicine and Associate Dean of Diversity, Equity, and Inclusion at Hackensack Meridian School of Medicine in New Jersey, discuss a patient case that highlights how health disparities can impact non-valvular atrial fibrillation management and strategies to address these disparities to improve patient care. For more information about Dr. Ferdinand and Dr. Kountz, and for a link to the full online educational program, along with a CME, CE certified on-demand webcast with downloadable sign sets and a clinical thought commentary, please visit the show notes for this episode. Now let's get started and hear what Dr. Ferdinand and Dr. Kountz have to say about addressing social determinants of health in patients with non-valvular atrial fibrillation.
This is Dr. Keith Ferdinand at Tulane University, New Orleans, and I'm speaking to Dr. David Kountz, who I've known for decades. And you're going to talk to us about a case and some of the aspects related to atrial fibrillation, non-valvular atrial fibrillation, and some of the risk factors and social determinants of health. Dave?
Dr. Ferdinand, Keith, great to see you, and thanks for the opportunity to chat with you today. So I want to tell you about a lady I took care of when I was on rotation as a hospitalist at my hospital a few months ago. And she was an African-American woman in her late 50s. She had non-valvular atrial fibrillation and other risk factors and met criteria for chronic lifelong anticoagulation. She was on warfarin and had issues with poor compliance. This was my first time caring for her, and she had a non-life-threatening bleed when I was her attending physician. As I got to know her a little bit, I realized that this was her third admission in the last 3 months, and she had had previous admissions in prior months and in prior years. She lived in the community near the hospital. She had several daughters who I was able to contact, and as I got to know them, a couple things became evident. One was she did not have a reliable, consistent source of primary care. And the second was her daughters had a misunderstanding that it was normal to be frequently admitted with bleeding as a result of warfarin therapy. This by itself saddened me that as a group of clinicians, we hadn't set a higher expectation and figured out a way to follow up, because no one should have the expectation that they're readmitted to a hospital several times a year with bleeding that at some point would become life-threatening.
You know, Dr. Kountz, that's a real problem. Although we as clinicians try to do the best, sometimes we have a bias and we get that message unintended to the patient that somehow their disease is, quote, normal for them. You know, having bleeding episodes, having a blood pressure that's poorly controlled, an A1C greater than 7, well, that's just the way it is. And what I'm hearing from you is some of these adverse outcomes are then accepted by the patient as being part of their very being. I guess it goes back to the old essential hypertension when we thought elevated blood pressure was necessary for a person to survive.
Yes, I think so. I also, when I sat down with the daughters and the patient is very passive. She is the type that a nursing unit would say, boy, this is a great patient. She's very adherent to our recommendations. She didn't feel confident, perhaps questioning in a collaborative way her physicians and her nurses. And I think as a result, it was always just assumed that she understood recommendations, she would follow up, she would nod in agreement. And it was a good lesson learned for me that we have to look below the surface sometimes and remember that patient's history and say, wait a minute, I can't just hand her a bunch of prescriptions, especially since she's been readmitted so frequently. I've got to delve a little deeper, understand why and how this is going to be different than her prior admission. So one thing that I wanted to be different was to switch her from warfarin to a newer oral anticoagulant, a DOAC. I asked if she had heard about these drugs before, and she seemed to have a little bit of understanding. It may have been that a well-meaning physician had had the conversation previously, but it never went anywhere. And speaking again with her and her daughters, they had a great deal of anxiety about switching medication. And no one had really sat down with them and given them the confidence about the benefits of newer medications. They were already a bit anxious about the healthcare system. And then one more bit of anxiety was switching medication.
You know, what I'm hearing from you are two things. One is that we have some biases, we as clinicians, and we don't take that extra step to help the patient understand that there may be alternative means, in this particular case, to control the potential for stroke with atrial fibrillation. The second one that I'm hearing is that we sometimes allow the patient to accept the fact that they're going to have complications and multiple hospitalizations, that's the normal way. So you're struggling with that at the clinician level, but I know there are other potential sources of disparities. So perhaps tell me how you overcome that problem as a clinician, and then talk about the levels that are beyond us, the healthcare systems level that we don't really control, but we should make some effort to help the patient navigate.
Yeah, so I think traditionally we think that our involvement kind of ends when the patient walks out of the hospital and they're kind of left on their own to find the clinic, to find the office, to navigate the pharmacy. And again, in my training, it was kind of, those are the patient's issues. But I think that the really important new approach is those are collectively our issues. So I need to take accountability, not only for the care I'm providing that patient in the hospital, but really to negotiate the complexities of our system to get that patient to the next level of care, to ensure that they have a way to fill that prescription. So how do we do that? So one is something we've talked about already in this scenario is to engage family, and just spending a few extra minutes with the daughters really kind of open their eyes to, no, this is not something that we should expect, not something we should say is the standard. And let's figure out a way so that mom doesn't have to come back to the hospital. So that was, I think, a really positive conversation. Two was to say, we have newer medications, and in your mom's case, it can really help reduce those swings in the level of anticoagulation, give her more freedom with regard to her diet, reduce the frequency that she's supposed to come back for testing. And they loved hearing that. And I do think clinicians may have tried to have those conversations. Maybe I was the fortunate one that really kind of got the message through to the family. Third was to try to identify community resources. And I think many clinicians have something similar to what I'm going to describe available to them. In our case, we have added a module to our electronic record system that actually goes through social determinants and provided a way for me and our nurses and others involved in this patient's care to have a broader understanding of what resources were available in the community where she lived. And this included everything from different pharmacy prescribers to social service agencies. Her family lived in the area, but not really specific to her local community. So we were able to share information through our system to give her and give them more specific community resources that I don't think they had received on prior hospitalization. So it was a lot of what we should be doing anyway. It was sitting down, really understanding where that patient and their family were coming from, providing some optimism and information about newer therapies, and then connecting them to community resources and conveying that your problem is my problem, that this does not end here at the front door of the hospital, that we were going to see through how to make sure that you stay healthier or healthy in the community and don't have to come back here in the next couple of weeks.
Wow, Dr. Kountz, you did a great job telling me how you personally overcome some of the barriers we have as clinicians in giving appropriate care. And I'm also intrigued that at the healthcare systems level, there are steps that are being taken to remove some of these barriers. But, some of my colleagues say, well, it's not just about us or just the system. The patients themselves have patient preferences. Some of them have treatment refusal or have adverse care-seeking behaviors and attitudes. How do you deal with that?
I agree with you about that. And we can't forget that patients are integral into this discussion. We can do things as clinicians. We can work with resources available through our health system, but we have to understand, again, where that patient is coming from. Some of their perception and decision-making is around mistrust. I mean, something I've heard you speak about many times. And it's difficult sometimes as in a single encounter to overcome what can be decades of mistrust and suspicion. The idea that I'm giving them a new medication, well, is that really in my best interest? And even though I had some problems with the older medications, I'm accustomed to it. So there are times when we have to approach these all the time. We have to approach these discussions with a degree of humility and understanding that perception. I think it takes something I heard a very good clinician I know say to me. It's taking one's time. It's making sure that questions are addressed. It's having an acknowledgement that they may have had a difficult encounters with a physician, physicians, or the healthcare system. So absolutely, to your question, patients are an important part of this. And not every time you want to make a change in medication or recommend some different approach is it going to be accepted. There are times, I'm sure as a cardiologist, you've heard us from a colleague that I referred a patient to you and you say that patient never showed up. Well, they may have had very difficult encounters with specialists and they're anxious about that visit. So we just have to redouble our efforts. We have to know this in the background. We have to have a degree of patience, as I said before, humility. But I think at times we can overcome that with an awareness of the issues our patients may be dealing with. So I push through, I acknowledge some of their concerns, but I think if I can convince them that my interests are for their best health, that most times I can overcome some of these historic concerns.
Thank you so much, Dr. Kountz. You've given us a great example how we as clinicians can address some of these barriers at the provider level, at the healthcare systems level, and at the patient level themselves. So perhaps give me one or two take-home points that you think will be overarching in terms of the discussion that we had today.
Well, thank you again, Dr. Ferdinand. As I think again about this patient, I say whatever happened in the past, don't accept it. I think that it would have been easy to just quickly care for this patient, one more admission for challenges with over or under anticoagulation, and just write her more prescriptions and send her on her way. And what I often say to my residents is what takes clinicians from good to great is challenging assumptions and may be what has happened in the past. So one of the lessons learned was educating the patient, as basic as that sounds, and educating the family and looking at the trends and saying, it's not normal. It shouldn't be something you accept. That mom keeps coming back to the hospital. Let's see what we can do differently. Another take home was listening, really, really listening to the patient's concerns about issues in the past, acknowledging them, but providing them a path forward. And then taking advantage of some newer medications, which are safer, which are more convenient, and figuring out through what you can do as a clinician or through your hospital, health system, pharmacy, or other resource, how to get that newer, better medication to your patient. Those were some of the takeaways that I would like to share with my colleagues.
Well, thank you so much, Dr. Kountz, for such a stimulating conversation.
Thank you very much to Dr. Ferdinand and Dr. Kountz, and thank you to the listeners for joining in. We hope you have enjoyed this podcast and invite you to listen to our other podcasts covering more strategies to address social determinants of health and non-valvular atrial fibrillation if you have not done so already. As a reminder, to view the full program, click on the link in the show notes for this episode. As always, thank you for listening.